The interesting observations that have been made about COVID-19 and prostate cancer actually stem from the observation that TMPRSS2 may be involved in viral entry into normal cells. And when one looks at the Italian data, where they do a multivariate analysis, and they look at those patients who have a per 300,000 serious events or deaths that were recorded related to COVID, prostate cancer patients on hormone therapy have a much lower rate of those events than prostate cancer patients who aren't on hormone therapy or the general population. So how do we explain that? Well, it could be that simple observation that the anti-androgens or the lack of testosterone is having that effect. We do know that the disease is more severe and more prevalent in men. It also could be that those patients who are on hormone therapy are more debilitated. They tend to more socially isolate. They may not be exposed to the virus in the same fashion. So there's a lot, I think, of hypotheses that can be generated. I wouldn't make the immediate assumption because you're on hormone therapy that you're going to be immune to COVID infection. I'm not saying that at all, but this is something that people are now investigating. And there are a variety of different clinical trials that are being designed in different states of COVID infection, whether this be asymptomatic patients versus patients who are hospitalized, trying to determine whether viral load changes with various different anti-androgens or whether hospitalization or the respiratory parameters change. The VA just opened up a trial that's looking at degarelix in men who are in the ICU to see if they can shorten their stays. So I think that these are some very, very important hypotheses that need to be borne out. As far as my practice is concerned, there has been a huge effect on patients, on staff, on physicians. So on patients, of course, some are afraid to come into the office because they're afraid of infections. All of our patients are wearing gloves. We pre-screen all of our patients in terms of symptoms the night before. We are not requiring, as some institutions do, that patients have a negative COVID test before coming. I am face-to-face seeing patients who are going to be treated. I have not changed my algorithm in treating patients based upon this particular pandemic. Actually, in fact, I have not missed any time seeing patients, although I may see more video visits. My video visits, I think, were about 60% at one time. Now they're about 50%. I am seeing all of my patients face-to-face who need treatment with chemotherapy. And that's still ongoing for both patients with prostate cancer as well as for bladder cancer. So I think that the NCCN guidelines are helpful in understanding how we should deal with our patients, but you have to look at the individual patient. And again, the risk of COVID versus the risk of what's going on with their cancer. What concerns me the most is data that's come out suggesting that the rate of new cancer diagnoses is down by 20%. And I also have known from personal experience, just seeing patients and also seeing family members, that by being isolated in a house for 2 months, your conditioning goes down and your ability to tolerate things go down, especially men with prostate cancer on hormone therapy, where we're trying to maintain their muscle mass by exercise and by weightlifting and other ways of doing so. So that's something that is I think, maybe overlooked. You've still got to exercise. You've still got to be active, whether that be in your house, whether that be somewhere else, but you still have to do it.